CT chest, abdomen and pelvis. Pre and post contrast. Clinical info. RTA with trauma to abdomen. Serious condition of patient and CT done as pre-op assessment. Technique. 2.0 mm reconstructed images from a scan performed on multi-slice CT scan. Reviewed on workstation using different window and level settings. Post-contrast CT chest with pre- and post-contrast CT abdomen and pelvis is performed according to departmental protocol. Findings. Chest. Lungs are clear. There is no patch of ground glass attenuation, consolidation, collapse, pleural effusion or pneumothorax. No definite lung parenchymal nodule, bronchiectasis or evidence of interstitial lung disease is seen. Thyroid is normal. There is no axillary, supraclavicular or mediastinal lymphadenopathy. Heart is normal in size. Cardiac chambers and major mediastinal vessels are well opacified and patent. There is no evidence of mediastinal hematoma or emphysema. No pericardial effusion is noted. Esophagus does not show any abnormality. Gastroesophageal junction is collapsed. Trachea and major airways are clear. Chest soft tissues are symmetric. Abdomen and pelvis. Liver is normal in size and has smooth margins and patent vasculature. There is no focal hepatic lesion, intra or extrahepatic bile duct dilatation. Gallbladder is normal without any radiopaque calculus or pericholecystic strandy changes. CBD is normal in caliber without any radiopaque calculus or biliary dilatation. Pancreas shows normal enhancement. There is no focal mass lesion, parapancreatic strandy changes or fluid collection. Spleen is normal in size showing normal enhancement. Adrenal glands are normal. Kidneys are normal in size with smooth margins and preserved parenchymal thickness and show normal enhancement. There is no radiopaque calculus, mass or hydronephrosis. Ureters are normal in caliber. Urinary bladder is collapsed with Foley's catheter bulb in place. Stomach, small and large bowel loops show no significant abnormality. Ileocecal junction is normal. There is no pneumoperitoneum or features of obstruction. There is no significant abdominopelvic lymphadenopathy. Aorta, IVC and rest of the opacified major vessels are patent. In visualized osseous structures, there is comminuted minimally displaced fracture of left pubic bone and superior iliopubic ramus. Fracture of anterior part of left inferior iliopubic ramus is also seen. There is minimal diastasis of pubic symphysis. Buckling and non-displaced fracture of right inferior pubic ramus is also seen. There is comminuted fracture of right sacral ala with few small displaced osseous fragments. No significant diastasis of bilateral sacroiliac joints is seen. Hip joints are normal. There is associated mild to moderate hemoperitoneum and retrohemoperitoneum in pelvis with associated severe fat stranding and soft tissue edema. Mild hemorrhage is also noted in presacral space. Superiorly, the hemorrhage is extending in bilateral parasolic gutters and right hepatorenal pouch. There is no evidence of contrast extravasation from major abdominopelvic vessels. Right testicle is normal. Left testicle has heterogeneous appearance with associated free fluid and hemorrhage in left scrotal sac. Impression. Comminuted fracture of right sacral ala extending up to sacral foramen, with few minimally displaced osseous fragments. Associated mild hemorrhage in presacral space. No additional fracture in visualized spine. Diastasis of pubic symphysis with comminuted non-displaced fracture of left pubic bone superior and inferior pubic rami, buckling and non-displaced fracture of right inferior pubic ramus. Associated mild to moderate pelvic hemoperitoneum and retrohemoperitoneum, proximally extending in bilateral parasolic gutters and Morrison's pouch, consistent with sequelae of recent trauma. Heterogeneous appearance of left testicle with associated free fluid and hemorrhage in left scrotal sac. Clinical correlation is recommended to rule out possibility of left testicular trauma. Collapsed urinary bladder with Foley's catheter bulb in place. Possibility of vesicle injury cannot be entirely excluded in the absence of delayed phase. No evidence of hepatic, splenic, renal or pancreatic injury. No abnormal bowel dilatation or pneumoperitoneum. No definite pleural effusion or pneumothorax.